My name is Sam Smith. I'm the co-founder of Click IT and president here in Louisville, Kentucky. I guess we named the company correctly because Dr. Ellis thought when he was reading this that Click IT was his instructions, click it. And then McCarran said the clicker's on stage, so here I am. But anyway, Click IT was founded in 2013 here in Louisville. We now have offices in Cincinnati as well as Dallas, Texas. And our sole focus is on the technology verticals for helping our clients in the areas of technology professionals on a direct hire basis or a project basis. Our expertise includes application development, project management, cloud services, and analytics. And in addition to that, we have a very experienced healthcare specific team that assists our clients with EMR selection, optimization, and go live support. So with that said, the future is here when it comes to technology-enhanced treatments for common psychiatric conditions such as depression and anxiety. Our next presenter's primary work is in psychotherapy, particularly in computer-assisted cognitive behavior therapy for depression. And today he will illustrate treatment, review relevant research, discuss advantages, disadvantages, and challenges these treatments present, and conclude with a consideration of future directions. Please welcome Dr. Tracy Ellis.
Thank you. Very nice to be here today. Let me apologize in advance because I don't have notes. I'm going to be probably looking up here to look at my slides. So the work I'm going to do today is done under the auspices of the Louisville Depression Center. The head of the Louisville Depression Center is Dr. Jess Wright. Much of the work I'm going to be describing is really his work. He's the innovator he's the PI on our grants. He's currently on vacation. He's returning from vacation. I'm told he's in flight from a week or so in Italy, but I'm very pleased to present in his stead. The Louisville Depression Center is one of 25 centers of excellence in the United States. There's a network of centers. It is a regional, it provides resources regionally for evidence-based treatment for depression and bipolar disorder, as well as educational programs and research. I'm going to show you the title of the talk. Can technology enhance treatment delivery? To cut to the chase, yes, that's the main point I'm going to be making. I want to make some disclosures. I received some royalties, and there's some grant dollars up here. Dr. Wright, likewise, the key difference between my disclosures, Dr. Wright's disclosures, is he owns the software product that I'm going to tell you about that we've done some research on, okay? So what we want to do is talk about the advantages and disadvantages of computer-assisted therapy. I wonder if I can get this to work a little better for me. Does this thing come off? How do I get it off? I want to get it a better... This thing says time is holding fast, not moving, so I still have 40 minutes to talk? Okay. This is better. Hope this works for you. We'll talk about the advantages and disadvantages. Oh, I just lost 5 minutes. I was fast. All right. Advantages and disadvantages of computerized cognitive behavioral therapy. CBT, computer-assisted cognitive behavioral therapy. Some research, some illustrations, some apps, and then future directions. For those who may not be familiar with cognitive behavioral therapy, there have been literally thousands of psychotherapy studies exploring CBT for treatment for many, many conditions, including depression. And they show the effectiveness of this approach to psychotherapy. It's not medication, it's psychotherapy. It's talk work, and it's the patient engaging in doing activities. The fundamental assumption of CBT is that our thoughts shape our mood. How we think about events makes a huge difference in the mood that we experience along with those events. Coupled, that's the C part of the CBT. The B part, the behavior, that refers to the things we do that support a psychologically healthy lifestyle or do not. All right? So, on to the talk. What are the advantages of computer-assisted psychotherapy? One is cost. It's just simply cheaper. Once you've got the program developed, there's significant cost in those, but once you have the program developed, it's cheaper to deliver the treatment to patients. In one of the studies I'm going to describe, we were able to cut therapist time by 2/3, all right, which you can translate into cost, while delivering a treatment with the exact same outcome. There's also advantages in access and convenience. Anyone with an internet connection and an iPhone or a telephone can participate in the work I'm going to describe. There are some patients with social anxiety, for example. They don't want to leave the home. They come out. They can work from home, engage in the program, and then over time, hopefully, develop the courage and the resources to venture out. These models deliver evidence-based treatment. I told you about those studies. These are designed to incorporate within them the principles of the studies and the steps that go along in these studies. Many of these programs are immersive. Virtual technology allows you to safely put a person in a situation where they're kind of experiencing the things that are sort of triggering their anxiety, for example, and to help them to learn to master it. So with virtual reality, for example, you can have a person wear a device on over their eyes, and if they got, let's just say, spider phobia, you can put little spiders there, and then you kind of calm them down. They learn, and you make the spiders bigger and bigger until they're able to master it, okay? You teach them things, coping skills in advance. Same with acrophobia, fear of heights. You can, put people into situations where it looks like they're sort of like this, but the drop is much faller, much greater, and they can learn to master that. I'm going to show you a little video demo later on in the presentation that will illustrate this to some degree. It's focused on social phobia, and the part of it I want you to look at is there's a group of people who are sort of large on the screen, sort of looking at you if you're the person doing the work, and some of them kind of have frowns on their face and so forth, and the idea is to put you into this situation so you can learn to master the anxiety. All right, these programs have built into them education, psychoeducation, skill building, tests, progress reporting, all of these things, self-monitoring, and homework. And then they're very useful for data collection and management. What are some of the disadvantages? It's very challenging to develop software. There's so many questions. The analogy that comes to my mind is 10 years or so ago, my wife and I decided to build a house, and she took on the task of being the general contractor. We hired a bunch of subs, and we were amazed at all the details that went into building a house. I mean, from the cabinets to the things that line the floorboards to what color of beige we're going to paint the walls, et cetera, et cetera. And very similar to this, there's enormous detail, and you want it to be a warm experience for the patients, and you need to make it or to design it so that it does deliver the evidence-based treatment. So that's challenging. Adoption by clinicians. This is still a very new thing, and some clinicians may find this kind of thing threatening. Although we'll see that the research shows that a clinician role in this is computer-assisted therapy. The clinician role is still an important one. Other challenges, insurance coverage. Insurance does not cover the patient sitting and viewing these programs. It will cover the clinician time, but that's it. We do need more research. The research in this whole area is accelerating rapidly, but we need more. And then moving from a randomized clinical trial environment, which is highly controlled, is very different from the delivery of these treatments in the real world, and there are problems that arise when you try to disseminate it. We're currently finishing a dissemination trial. We'll talk a little bit about that today. So I want to move on to talk a bit about various methods of computerized psychotherapy. Most of them, as I've said, are based on CBT. I've described that to you. I've talked to you a little bit about virtual reality. Some of the programs are simply text-based. All right, so a person will log on to a program and there will be reading material there. We're moving away from that now, but some of them are designed that way. The ones I'm going to be describing for you today are multimedia. They're the one that Dr. Wright devised has live action, role playing, and so forth. And then there's mobile applications. And we'll talk a little bit about that. So I want to move on to a few studies we've done on computer-assisted CBT for depression. I'm going to describe, I'm going to show you a little bit about Jess's program first, which is called Good Days Ahead. This is an internet-based program. It's got 9 separate modules. 7 of them are learning modules. 2 of them are review models. They lead an individual through a treatment for depression, a cognitive behavioral treatment for depression. It includes, as I said, live video. So here's, I don't know how to get this thing to work. You can see the character up there, Kara. There's a scene here that plays. She's sitting over coffee with a friend. She's saying things like, I just don't feel like myself anymore ever since, I'll make this up a little bit, ever since my child went off to school. I'm sitting alone at home and I'm just not feeling myself. I wonder what I ought to, I just don't know what to do. Her friend, says, well, have you considered therapy? And, oh, what's that about? She describes it a little bit. And then there's another scene where she's meeting with a therapist. There is psychoeducational information up here. There's homework. There's ratings. Patients start off by rating their depression, and over time they can see their success in reducing their symptoms. Another shot of the program, you can see to your left the different modules moving through identifying these thoughts that I described that affect mood, to labeling them, to then modifying them, and then to taking action, and so on. Another screenshot, this shows the patients are seeing this, can see this, can see their progress. And the therapist can also log in and check between sessions how the individual is doing through the treatment. Are they actually engaging in the treatment? Are they participating? This is, as you can see, very different from taking a anti-depression medication, in that with that it's sort of passive. You take it and you hope it improves your mood. With this, it only works when the patient engages and does things between the sessions. All right, I'm going to describe some studies for you. These are the participants in the studies. I want to put this first one into context. This was published in 2005. This was published in 2005. It started a few years before that. In those days, there was a great deal of skepticism about the whole idea of using a computer to help with psychotherapy. People would think, well, how, a computer, that's cold. People are warm. You need a human being in the room. How can a computer actually do this? There was and there was very little research in this area being done at that time. There had been some work done, and one of the early innovations was rather interesting. In the mid-60s, a computer scientist at MIT developed a program called ELIZA, E-L-I-Z-A, which was designed to mimic a Rogerian therapist. Rogerian therapy is different from CBT. It has certain principles that are followed, one of which is that the therapist makes reflective comments back to the patient. So the patient says, well, I feel very sad. The therapist says, I hear you're feeling very sad. Yes, doctor, I am. How did you know that? Anyway, yes, I'm sad and I just don't know what to do. My life seems empty. The therapist might say, and your life seems empty and you don't know what to do. I'm oversimplifying it, but ELIZA was developed and it got a lot of attention. And I'd say there were two outcomes, from this that influenced the future of computer-assisted therapy. One was some people who worked with ELIZA connected in some way with ELIZA. They bonded with ELIZA. You can go to a website, actually, if you want to Google at some point, ELIZA, the Rogerian therapist. The program will come up and you can interact with it. Maybe you'll get some sense of how an individual might feel almost like they're talking with a real person. So that was one kind of thing that happened. Another thing was that it was easy to trip up the computer. All right, so it would come back with kind of ridiculous things like, I gave you a little bit of a scenario a second ago, and so suppose you type in, why are you repeating everything you're saying? I'm saying. It might come back and say, this is about you. This is about you. This is not about me. All right. Yes, but you're the one who's repeating everything I'm saying. And it will say, this, will repeat the same thing. And it just gets in these loops and it looks ridiculous and it became the butt of a joke. And little research followed for the next few decades because it had just seemed like too large a task. So when people returned to this kind of work, it was a different kind of model, like I've described for you here, where the computer is assisting the therapy. The computer is not used to actually mimic an actual interaction with the therapist. So that's the context for this study. It was a small study, and the hypothesis was, will computer-assisted therapy yield similar outcomes to therapist-delivered studies? All right? So in these studies, patients were 45 patients randomly assigned to therapist-delivered cognitive behavioral therapy or the computer-assisted. In the computer-assisted part, the therapist time was cut in half, and then the therapist would, rather the patient, would go to a separate room, get onto the computer, and run through these exercises that I described. At that time, it was on Laserdisc, all right? It wasn't on the internet. And it was a rather shortened version of CBT. Eight sessions is shorter than often is the case. So what were the results? As predicted, as hypothesized, CBT was equivalent. The CCT, computer-assisted cognitive therapy, the red line, had a similar outcome to the cognitive therapy, the dashed line. There's no difference between these. And the wait list control showed no improvement whatsoever. Thrilled to see that result, all right? To say a little bit more about it, these D scores are scores of the magnitude of the change. How strong was the change? And these are large numbers. What these numbers around 1 mean is that about 85% of people in the CCT and the CT arm of the study were better off at the end of it than those in the waiting list. So about 85% difference. That's a huge difference. I mentioned no significant treatment differences, and also importantly, patients accepted it. They were willing to engage with the program. And one measure of that is that the dropouts were about the same. This is a standard level of dropout. Okay, we moved on to another study. That first study was small. It was sort of in-house. It was done by people who were major adherents to this approach. So we wanted to do a bigger study, do a multi-state study, be a little more relaxed in the level of the severity of depression and other conditions a patient might have to be enrolled in the study. And we did that, teaming up with a group of folks at Penn. We had 154 subjects in this one, more than 100 more than the previous one. Again, they were randomly assigned to standard CBT or the computer-assisted. There was not a wait list in this one. That was for ethical reasons, because we know that CBT is effective. It seemed questionably ethical to deny treatment when we know that it can be helpful. And the hypothesis was equivalence, basically, equivalence in outcome. Okay? And I said I would show you the study where therapist time was cut by 2/3. In the computer-assisted arm, it was cut by 2/3. In this study, the patients still came into the clinic, see their therapist. In the CCBT part of the study, they came in, they saw their therapist face-to-face, then they went down the hall into another room where they did the program. This is, again, before the days when this was on the internet. What did we find? Again, you can see in the red, the CBT, in the yellow, the CCBT. There is equivalence in outcome. These are Hamilton rating scales. It's just simply a scale to measure severity of depression. A 20 at the pre-treatment is moderate to severe level of depression. 10 is the cutoff. So you can see at the end of the 16 weeks, in both conditions, the average patient was below a 10. So again, demonstrating the effectiveness of this approach with a larger group of patients, a more heterogeneous group of patients, more comorbidities, and 2 sites. This is a conference on aging. I do want to say that there were some individuals in these studies that were over 65. There weren't enough, though, to run separate analyses on the outcomes here. I do think that the basic principles that I'm describing for you and these outcomes are very adaptable to an aging population. Okay? Although the form of depression for aging people is, the profile, if you will, of depression tends to be different for older people in some ways than younger folks. We are currently doing a study, we're just wrapping it up, where we're taking it this additional step. I mentioned challenges of disseminating the study, and disseminating the program. In this one, we're working in 4 rural sites, 3 urban, 1, we're working at 4 primary care sites, 3 urban, 1 rural. We are comparing the CCBT with treatment as usual. In this study, we don't use, the patients on the CCBT do not come into the clinic to receive the treatment. They get it entirely online. They have a coach. This is a licensed therapist, but the coach calls them weekly. They have about a 20-minute conversation. All right, so it's pushing it more out into the community. And what we're predicting here is not equivalence of outcome between the treatment as usual and the CCBT, but superiority of the CCBT. We've done just some preliminary analyses And it looks like that is exactly what the data are showing. All right, that's Good Days Ahead and the studies we've done on that program. I want to just make you aware of a couple other programs and show you some research that really gets to the question of how important is it to have a coach or to have a therapist, assist with the delivery of this computerized program. One program, very much like Good Days Ahead, is Beating the Blues. It's designed not to have any therapy, to be completely self-administered, all right, to not have much assistance from a therapist. It's about the same number of modules. It's very similar in design to Good Days Ahead. It uses these graphic figures, whereas Good Days Ahead does not. It doesn't use the live action scripted material. So, there's that difference. Oops, uh-oh. All right. Just another look at Good Days Ahead. I'm sorry, at Beating the Blues. This was a study where they compared it with treatment as usual, and what they found was that you can see the two yellow lines, basically, that the computer-assisted therapy was more effective than treatment alone. Now, I did say that Beating the Blues was designed to not involve a therapist. In this particular study, it did. Okay, there was a nurse that was involved. There was what they call social counseling involved. It was not, though, one-on-one psychotherapy. So there was, in this particular case, some therapist involvement. Another one is called Mood Gym. And it's just very similar. This one has 5 modules, and they're all designed, again, to kind of replicate the cognitive behavioral therapy for depression. But you can see the design decisions in these that are made. Again, a graphic figure. Another study where, in this particular case, they used telephone support, much like we did in that last study I described, and they compared Mood Gym to treatment as usual. You can see that there was a difference, but it's not quite as big a difference, all right? So maybe there's something about face-to-face contact that makes a difference as opposed to telephone. Okay. I want to get to a larger study that's looking at unsupported CCBT. I'm going to get right to the punchline on this. And what you'll see here is 2 lines that run essentially in parallel. This is a meta-analysis. This is a bunch of studies that are put together. It's not a meta-analysis, I'm sorry, but it's a very large study. And they're comparing treatment as usual with both Beating the Blues and Mood Gym. This particular slide shows Beating the Blues in light blue, treatment as usual in dark blue. The Mood Gym results are exactly the same, and what it's showing is that when you don't have that support, some sort of human contact at the other end, you really don't get the results that you do when you do have that support. All right? Dr. Wright and I and a group of other large group of other folks did a separate study. This was a meta-analysis. We looked at 40 different studies, and we found all, again, comparing computer-assisted with waitlist or with other treatments, supported or unsupported. And again, you can see that the effect size, which is the measure of magnitude, was much greater in the supported than in the unsupported. So what's the bottom line? You probably need some support. The other thing we find is that dropout rates are much higher when, in the unsupported condition. Very briefly here, this top bullet point, what type of support makes a difference? Again, think of G like D. It's another version of D. It's a measure of magnitude. you can see that face-to-face leads to stronger outcomes, followed by telephone in these studies, and then email. So it's almost as if, the further away you are from the patient, the less strong the results are. And you can, I've mentioned the completion rate is also much stronger in the or the outcomes are much, this is sort of what you would predict, the outcomes are much stronger when the people actually move through the programs rather than dropping out as we go through it. And primary care had a significantly less positive outcome than in non-primary care settings. All right. I think I'm going to skip this one just for the sake of time. I don't want to leave time for discussion. I want to move on to CCBT for anxiety disorders. There's a similar body of research for anxiety as I've just described for you for depression. We've not studied anxiety ourselves other than we're doing a meta-analysis, but I did want to review it with you. I'm going to show you a video demonstration of a internet-based cognitive therapy treatment for social anxiety. David Clark, a major investigator in the UK, is the mind behind this. And as I said, the outcomes are essentially the same in these studies as in the studies I described for depression, meaning that there's equivalence of outcome when you compare with therapist-delivered and superiority of outcome when you compare with waitlist. So watch this video. I guess I click again.
The treatment is a series of modules. Some modules are designed for everyone, and some are designed for particular problems that some people have. Your therapist will work with you to make sure that your modules are in line with your needs. At the start, you will have access to 4 initial modules. Your first module is called Introducing the Treatment. Click on the module name to access the module. This, like the later modules, has been written to help you understand and overcome social anxiety. The pages contain useful information to read, including case examples. There are also boxes to complete and videos to watch which illustrate some key aspects of the therapy. There are also opportunities to hear from people who have already gone through treatment talk about their experiences. You have been allocated an online therapist to support you through the program. To send a secure message to your therapist, first click on Messages on the top menu bar, and then click Compose New. You can also read any messages which have been sent to you by your therapist. You will also see a notification of any incoming messages on your dashboard. As therapy progresses, you will be able to make use of the other useful features of the program, such as the experiment section, where you can plan and keep a record of behavioural experiments. Details of this are provided when you come to the relevant modules. You will also learn to make use of the Webcam section, which gives you and your therapist the opportunity to plan to speak to some other people as part of your treatment. It also provides the opportunity to practice giving presentations to a virtual audience. Both of these features are completely in your control. Again, more details will be provided when you come to the relevant sections. On the main menu, there is also a library section, which holds a collection of all the videos used throughout the program, including this one, and much else. You may watch a video again at any time, simply by clicking on the title.
That's it. You'll notice that this adds an additional component, which is the social media component. And I think that there'll be more and more of that in the future. I want to I think I've summarized this effectively already. It's basically showing that the results are essentially positive as they were for depression in studies of computer-assisted therapy for anxiety disorders. We do find, though, that you tend to get a stronger effect even without having, or even in the unsupported condition. All right, that's one difference. Appears to be the case. I'm going to move on quickly to apps. This is going to be short because while there are a ton of apps out there, we should proceed with caution. All right, there's potential here, but very few of these apps have undergone the kind of rigorous studies that I've described for you earlier in this talk. Many of them are developed without the involvement of psychotherapy researchers, and they don't have some of the security components that are built into these other ones in terms of breaches of confidential information, so forth and so on. And what I've just said to you by way of summary are the conclusions of a few reviews of this work. For example, I'll just quote this one: the app marketplace is littered with apps claiming to treat treatments, true, but the effects are much smaller, and it says only like just under 4% were rigorously treated, and of the 52 apps, more than about 2/3 involve no mental health professionals. Just another study essentially making the same point. I'll let you read that. Evidence base is scarce. That's the main point I want to make about these, along with the point that there's a lot of potential here, but I think that it's just in its early infancy. All right. Let's look to the future. What are the possibilities? I think there's many possibilities. We're going to have many, many more programs being developed. There's going to be more apps that will be developed. I think that these programs will connect more closely to people's lives. I could imagine apps where, let's say, an intervention for depression is that, go have lunch with a friend or exercise more, that you might have a device on your app that would sort of pop up at noon and say something like, the weather's nice today, have you considered taking a walk over your lunch hour? Oh, well, I told my therapist I would do it, a program told me to do it, and now's the time. Am I going to do it or not? Maybe that would be enough of a nudge to do that. Things like that, they'll push it out to people more closely. And there may be similar sort of things with elderly populations as well. So more interactivity. I think the app world is the future. There just needs to be more development in that direction. I read an article several months ago about games. Some of these might be gamified, and what I read was that what keeps people coming back to games, and there was this term, something along the lines of pleasurable frustration. That you're working hard at this game, you're at like level whatever 1, and you finally master it. You're kind of frustrated, you can't get it, but then you get it, so you're frustrated, you get it, that's some pleasure, you move it up, it's slightly higher. I imagine some of these apps are going to incorporate this kind of concept of pleasurable frustration to keep people connected and involved and moving through them, and not only after or during treatment, but post-treatment to help the depression or the condition, whatever it may be, not relapse, not return. Okay, social networking will likely be in the future, and you could see how this was incorporated in that program that David Clark is running in the UK. And then finally, just broader dissemination. And with that, I'm going to show you a picture of Dr. Wright's children and engaging in virtual reality and open it up for discussion. I had a last slide said discussion, but that's fine. Thank you. Question? Jim?
Putting back up the photograph that we had up there just now. The gentleman on the left is Dr. Wright's son, he's a surgeon. And it's fact, he wasn't a surgeon when the program was written.
Correct.
I was involved from the business side, trying to figure out what the hell he was trying to do. I'm not sure, I still know, I've got a little reputation to that extent. And I'm not here to document Dr. Ellison, tell me what was happening, but just a comment. Andy wrote the original program.
Yeah.
When it was DVD. And when it initially went out, people bought it because they were looking for some sort of additional help. This was like 2002 or 3. So this has been an evolution in years. Second thing I would say to you is that they referenced earlier about Laura McRae, who was also an author. She is a professor at the University of Hawaii. She's participated in our studies with Dr. Ellison study. The two comments and then I'll sit down here about how I'll show it. When this program was first written, Dr. Wright, Dr. Ellison, Aaron Beck, Dr. Aaron Beck at the University of Pennsylvania was the originator of this concept. And these are not, I'm not going to give you the academic accurate answer. I'm going to tell you what happened. Okay? And not offensively, so you can't get it over. I met Dr. Beck in session. He was a really man, brilliant, quick talker, and he turned to me and he said, "What do you think CBT is?" And Dr. Wright looked at me like, "Don't screw this up." Okay? Because I'm through my company. And I said, "Well, here's how I can understand. You believe that the mood is driven by the way you think, so why not change the way you think?" And he goes, "See, that's what it's all about." And I think that's really important. Second comment I would make to you is the dissemination of this has been very difficult. And the reason is, number one, like it's not paid. The program itself is a very fair. So how do you get it out there? The other thing that came about with this is I practice CBT. I'm a man. I practice it for 6 years. And when I was describing it to Dr. Wright, he said, "You can't do that. That's CBT." I know. And essentially what it is if you help people think their way through what they're thinking, they do miraculous things. Miraculous things. And notwithstanding all the brilliant work that people like Dr. Ellison and Dr. Wright have done, it's a practical thing we already know. Obviously, I'm excited about it. I wish it would be further along. Last thing is there were two mentioned two other programs, Beating the Blues, which was a British choir, and Blue Kid, which was an Australian choir. Both of them were good at essentially about government. And they were used with varying degree of success. The other thing I would tell you is it is a military part. Some years ago, we had a major part of suicide, and we used all kinds of lyrics. So it has, this has been documented in that way. So it's exciting, my point of view is with healthcare, when you look at this subject of mental health, it was as far behind in terms of technology as any part of medicine. And today, that's not true. The question is how to move forward. Would you agree with that, Dr.
I most definitely would agree. Absolutely. And, Dr. or Mr. Fleming's talk this morning, in his talk, he talked about, with people wanting to stay in the home as long as possible. You can bring these apps into people's homes, and that can facilitate that. Is there another comment or question? Yes, please. The question was, is this available for free or is there a cost? This particular, the Good Days Ahead is not available for free currently. I don't think we've ever charged anybody for it. We've used it essentially in studies, so there's not been a charge for it. There are, I think it's the Beating the Blues is restricted to people within that country. So it's a little bit difficult for someone to just go in and log in to any of these unless you reside in the country, and there's legal reasons for that.
So do you, your comment before about dissemination and availability and the fact that 2/3 of them didn't have any medical professionals involved in development, do you see any future in having medical groups do something like a seal of approval on mobile apps?
I would not view it so much as a seal of approval as get the researchers involved at the beginning on ground one, so you can study these, so you can develop them, and you bring people with different kinds of expertise in early, so that they can design apps and then study them and see how effective they are, and then redesign them to improve them, and then over time you'll have similar results or better to what I showed you in these first studies. And then there'll be folks who will, you write these up in studies, they will essentially apply a seal of approval because they're reviewing the research results, and that will demonstrate the effectiveness of these. That's how I would approach it. Yes, sir.
Is there ability to gauge generationally where this type of therapy is becoming more and more accepted? Obviously, you've got a younger generation that is more social, more technology acceptable, and then from a healthcare delivery, they're more fix it now, fix it rather than having relationships with multiple providers, if you will, to help them with their own. Obviously, you've got an older generation.
Right.
That's still coming to grips with having to engage technology for a platform used to get better. All
Right.
facets for mental. So is there information that basically indicates where this market is going and where it's more acceptable?
I have anecdotal data I could share, which is that it's more accepted by younger people than older people. The other thing I would say is in this last study that I described, our dissemination study, we do include people from all walks of life and socioeconomic levels, and some we had to provide them the hardware, the computer, in order to do it. They couldn't afford it, and then there were groups who did need some coaching on how to kind of get it going, and there was a minority of people who simply did not engage with it, couldn't sort of connect, if you will, to the program. But by and large, the group as a whole did. Once they got in, they kind of figured out how to move around in it. They felt some sense of control over it. They connected to it. There was I know one, I say connected to it, and I think there actually is some level in which people emotionally connect with these programs. They see them as helpful to them.
Can you comment about, you said this is an aging, you said it was a different profile.
Yeah, very briefly, I would say depression looks a little bit different in the elderly than in the non-elderly, in that elderly folks are somewhat less likely to report sadness and just to report depressed mood. They're more likely to report somatic symptoms, poor sleep, low energy, and so forth. They're also more likely to report anhedonia, lack of pleasurable feelings. All right, but also half of depressions in the elderly are first onset depressions. These are folks, half of them, who have not been depressed previously in their lives. About a third of people who are recently widowed are likely to get depression. About half of those are still depressed after a year, so there's a good opportunity there. I think I'm getting the hook, so. I'm getting the hook, so. What percent of medication? Is treated with medication? Oh, well, I don't know the answer to that question. but there are side effects of some medications that can cause depression, and there are certain medical conditions, heart disease, diabetes, stroke, that can trigger a depression, and those, of course, are more common in the elderly.